So this is the overview for Chapter 3. In the beginning of Chapter 3 and Chapter 4 is really kind of the heart of all of my talks, and Chapter 3 is where I'm going to really drive home this notion of a graphical representation of heart-lung interaction through the marriage of the Campbell and Guyton analyses. And with the basics learned in Chapter 3, then we'll move on to some applications to disease states in Chapter 4. And I really just want to be very clear at the beginning of Chapter 3 and certainly at the beginning of Chapter 4 that you know, what I'm going to talk about is not dogma. It's not like every patient is going to behave in this particular manner, but what I hope these slides can do is to stimulate interest in heart-lung interaction and also give some general basic principles that the clinician can bring to the bedside when evaluating a critically ill patient and assessing their hemodynamic parameters. So in health, I talked about this graphical integration of heart-lung physiology. So in Chapter 1 we talked all about the Campbell diagram, which related pleural pressure on the x-axis to changes in the static and dynamic properties of the respiratory system. And the movement of the cardiac function curve along the x-axis follows changes in intrathoracic pressure, as we saw with the Guyton analysis in Chapter 2. So if you put these together and maintain the x-axis as pressure, you can create kind of a somewhat busy, but I think the more that you appreciate and the more time you spend watching my lectures and studying the Campbell and Guyton analyses together, it'll become less intimidating and it'll really help bring alive what's going on in patients with very severe abnormalities in chest wall compliance, pulmonary compliance, airways resistance, and how that affects both venous return and biventricular function. So in Chapter 3 we follow this Venn diagram, and the reason that I tease out these effects is because the two major classical mechanical mediators of heart-lung interaction are changes in intrathoracic pressure, which I'll use interchangeably with changes in pleural pressure, and changes in thoracic volume. So this may seem kind of basic, but thinking about it in this way can help, it'll help you understand how each of these different changes in thoracic physiology affect the cardiovascular system. So common to both spontaneous ventilation and intermittent positive pressure ventilation is an increase in lung volume. And then there's decreased intrathoracic pressure, and if you consider just a decrease in intrathoracic pressure without a change in lung volume, this is essentially a Mueller maneuver. A Mueller maneuver is the opposite of a Valsalva. It's when you can sort of think of the patient sucking against a closed glottis. So you're lowering intrathoracic pressure, but because the glottis is closed, there's no airflow into the lungs and there's no volume change. So that is a Mueller maneuver. And if you consider effects on the cardiovascular system when performing a Mueller maneuver, you can help sort of tease out what are the effects of just a decrease in intrathoracic pressure as opposed to a decrease in intrathoracic pressure and an increase in lung volume, which you get, say, with a spontaneous breath. Similarly, if you consider the changes on the cardiovascular system as a result of only increased intrathoracic pressure, and again, many of you know this is a Valsalva maneuver without a change in lung volume. Again, this is increasing intrathoracic pressure against a closed glottis, so the intrathoracic pressure goes up, but there's no lung volume change. Then you can measure how the cardiovascular system responds and then determine how increased intrathoracic pressure affects the cardiovascular system. And when both spontaneous ventilation and Valsalva when both spontaneous ventilation and intermittent positive pressure ventilation have the same effects, well then you can, the common effects you can chalk up to the physiology of increased lung volume on the cardiovascular system. We'll talk about each of these in turn. And again, the two of these together kind of obviously increased lung volume with an increased intrathoracic pressure. Well, this is an intermittent positive pressure ventilation or positive pressure breathing, and then there may or may not be the application of end expiratory pressure there. So let's let's take a look at how decreasing intrathoracic pressure affects the cardiovascular system. So this is kind of a Mueller maneuver. And remember, in research, a Mueller maneuver implies usually a relatively prolonged negative inspiratory effort on the order of 10 seconds or so, and it's usually very pronounced. Intrathoracic pressures of -30, -40 centimeters of water. And I think you can appreciate that that's actually quite a bit different from normal, quiet, spontaneous inspiration when patients are only changing their intrathoracic pressure by, say, 3 to 5 centimeters of water. And obviously, they're changing lung volume at the same time. So this is somewhat artificial to call this a Mueller maneuver, but the principles are kind of the same. So remember, this is the Campbell analysis that is pushed back down into the screen. On the z-axis here is lung volume. This is chest wall compliance, and this is pulmonary compliance, and this is where they meet. This is functional residual capacity. And on the x-axis here we have pleural pressure in centimeters of water. So at functional residual capacity, the intrathoracic pressure is slightly subatmospheric. Again, this is 0, this is negative, and this is positive in terms of pressure. So when you perform a Mueller, or if you inspire against a closed glottis, on the Campbell analysis, you just drop intrathoracic pressure, so you're just moving laterally here along the x-axis, and there's no change in the z-axis, so there's no change in lung volume. This is my graphical representation of only a drop in intrathoracic pressure without a change in volume. So that's that left half of the Venn diagram that I just showed you. So again, as we talked about in Chapter 2, remember that the x-intercept of the cardiac function curve tracks changes in intrathoracic pressure. So if we were to repeat that experiment, this is the intrathoracic pressure at functional residual capacity, and it lines up with the 0 intercept of the cardiac function curve, and that's because, as I talked about in Chapter 2, if you were to uncouple venous return from from the heart, say for example clamp the IVC and the SVC, and then measure the right atrial pressure, the right atrial pressure would assume intrathoracic pressure, and at FRC, just before an inspiration or at the end of an expiration, that will assume the intrathoracic pressure here. When you unclamp the vena cava and allow venous return to occur, then it's the intercept of the venous return curve and the cardiac function curve that determines your right atrial filling pressure that you would measure with a catheter if you were to put the catheter into the right atrium like you get with a CVP monitor. And that's this pressure here, and again it's slightly above atmospheric pressure. So the distending pressure is the transmural pressure, and that's the pressure measured inside the right atrium less the pressure around the right atrium, and that gives you the wall stress on the right atrium, and that determines essentially the volume. And that's, transmural pressure determines volume, and that's the degree to which the volume increases is mediated by compliance. And here on the y-axis is blood flow. So at this right atrial filling pressure, you get this amount of blood flow at functional residual capacity. So if you were to repeat that quote-unquote Mueller maneuver and drop intrathoracic pressure, well, you can see the cardiac function curve shift leftwards relative to the venous return curve, because the venous return curve, for all intents and purposes, is subject to atmospheric pressure in the head and neck and in the abdominal splanchnic beds. So that doesn't really change, but the cardiac function curve shifts downwards with the drop in intrathoracic pressure. So now, even though the right atrial pressure has dropped, and you can see from here to here right atrial pressure is dropping, but cardiac output is increasing, and the distending pressure of the right atrium is increasing, which tends to suggest that the right atrium and right ventricle during diastole, of course, will distend. And as I mentioned, the increase in transmural pressure only suggests an increase in right ventricular volume, and that depends upon the compliance. But the increase in the RV preload this increase in RV preload is the greatest alteration in hemodynamics during inspiration, because there's normally a very small gradient between the mean systemic pressure and the right atrial pressure. It's on the order of 5 to 10 millimeters of mercury. So if the entire cardiac output is being returned to the right heart under only a gradient of 5 to 10 millimeters of mercury, just very small changes in the right atrial pressure on the order of 1, 2, 3 millimeters of mercury will result in very drastic changes in venous return and therefore cardiac output as the heart pumps it forward. So talking a little bit more in depth about the Mueller maneuver, if you look at various articles, there's conflicting results in terms of how a Mueller maneuver affects right atrial preload, right ventricular output, and left ventricular dimensions. So, some studies have shown that RV preload is increased, as I just showed on that previous slide. Some have shown that it didn't increase, and some have shown that right ventricular output is increased and not increased, and because of ventricular interdependence, left ventricular dimensions are altered or unaltered by changes in Mueller maneuver, and this can be very confusing. And certainly this is important at the bedside as patients are generating negative intrathoracic pressure if they're in extremis, how this can all be reconciled. In theory, as in the slide I just showed you, one would expect both the right ventricular preload and right ventricular output to increase with a lower intrathoracic pressure. The important thing is that, and I'm going to show this to you in the next slide, and this may be one of the reasons for discrepancies in findings, is that as the right ventricular cardiac function curve shifts leftwards along the venous return curve, if it hits that flow limiting portion of the venous return, which is usually it begins to occur at slightly subatmospheric levels, then no matter how low the intrathoracic pressure drops, there's no longer an increase in venous return. And that's not going to allow any augmentation in cardiac output, and it will have less of a distending effect on the RV and therefore less of a ventricular interdependence effect on the LV. Now, it's this great vein collapse that places a maximum limit on cardiac output. And what this next slide is going to show you, and this is just critically important to understand when you're at the bedside of a patient in the intensive care unit, because you will see patients with all kinds of volume status and all different kinds of right ventricular function, and these are really the two mediators of how decreases in right ventricular or decreases in intrathoracic pressure can affect right ventricular output. This great vein collapse is dependent upon the baseline mean systemic filling pressure, for example, the patient's volume status, and as well as the resistance to venous return, and the slope of the right ventricular cardiac function curve, which is determined, as we talked about in chapter 2, it's the slope of this cardiac function curve is not just contractile state, it's sort of everything summed into one. It's ventricular afterload, valvular function, contractility, heart rate, rhythm. All of these things will affect the shape and slope of this curve. So let's take a look at that quote-unquote Mueller maneuver that we just talked about on the previous slide. Again, just a drop in intrathoracic pressure, pleural pressure on the x-axis here. It's dropping. This z-axis is lung or thoracic volume going into the page. This is 0, so this is subatmospheric, and this is above atmospheric pressure. And as we saw, the right atrial pressure follows this decrease, so there's in intrathoracic pressure, so there's an increase in the distending pressure of the right atrium. There's an increase in cardiac output despite a decrease in the measured intraluminal. This is the intraluminal pressure. Even though this intraluminal pressure is now measured at 0, or atmospheric pressure, the distending pressure is actually increased because the intrathoracic pressure has dropped relative to the intraluminal pressure. And this is kind of a repeat of what we just talked about. But now I want to continue this thought experiment, and I want you to consider this next patient. So let's take the patient back to functional residual capacity, and let's increase their venous return curve. So this patient is now, we will say for argument's sake, this venous return curve represents euvolemia. This venous return curve represents hypervolemia. Now you can see the maximal venous return of this patient is much greater. The cardiac output for this patient is greater, and the measured right atrial pressure is greater, and that goes along with them being volume overloaded and a shift to the right of the venous return curve. So what's going to happen when we perform the same maneuver on this patient? Well, their intrathoracic pressure is going to drop. Their right atrial pressure will also drop, but not as much, but their distending pressure is greater for the same decrease in intrathoracic pressure. So this hypervolemic patient, this greater distending pressure will have a greater effect on right ventricular distension, and there'll be a greater increase in cardiac output and less of a drop in the right atrial pressure during the same inspiratory effort. So that's the hypervolemic patient with a normal cardiac function curve. Well, now let's repeat this thought experiment with a hypovolemic patient. So this patient was the decompensated cirrhotic with heart failure. This is your euvolemic guy off the street, and this is a patient that's in hypovolemic shock from pick your cause. Well, now their measured right atrial pressure is actually slightly subatmospheric, and they're on this flow limitation portion of the venous return curve. So at this point in time, because their measured right atrial pressure is below atmospheric pressure, or for all intents and purposes below abdominal pressure, the inferior vena cava is collapsing. So it's putting a speed limit on how much venous return can get back to the right heart. So now imagine this patient doing the exact same quote-unquote Mueller maneuver. Well, their intrathoracic pressure drops as a function of their intrathoracic pressure drops. Their measured right atrial pressure, or CVP, drops as a function of the decrease in intrathoracic pressure, but their distending pressure doesn't change at all. So look, same Mueller maneuver, different baseline volume status, no change in the distending pressure, and that's because as the right atrial pressure is lowering during this drop in intrathoracic pressure, the great veins are just continue to collapse, and so there's this speed limit, and venous return cannot be augmented. So this right atrium and right ventricle during diastole is not really going to distend all that much. So this patient may have minimal ventricular interdependence. They're going to have essentially no augmentation of their cardiac output, despite the same drop in intrathoracic pressure and drop in right atrial pressure. So this thought experiment helps illustrate how volume status for the same given Mueller maneuver, or the same given decrease in intrathoracic pressure, volume status plays an absolute critical role in the hemodynamic response to a decrease in intrathoracic pressure. Patients with a high volume status will have a greater distending pressure as a function of the increased venous return that you see for the same drop in intrathoracic pressure. Well, let's continue this thought experiment one more time, and let's look at, say, 3 patients, hypervolemic, euvolemic, and hypovolemic, but this patient has a poor cardiac function. So pick your poison. Why is this patient's right heart not functioning so well? Well, they've got some hypoxic vasoconstriction, some increased right ventricular afterload, maybe they've got ARDS, maybe they've got some valvulopathy, some tricuspid regurgitation, maybe they've got a little bit of heart failure, septic cardiomyopathy. You can name it, AFib. Their cardiac function curve shifts down and to the right. And now, just to simplify the animation, for the same drop in intrathoracic pressure, look what happens. The hypovolemic patient with poor cardiac function is going to have a much greater increase in distending pressure. They're actually not going to hit their flow limitation. So dropping intrathoracic pressure will continue to distend the RV, so this patient may have a significant ventricular interdependence. It's hard to know. All these patients are doing the exact same Mueller maneuver. The euvolemic patient, it's even greater, the distending pressure you can see. Their cardiac function, or their cardiac output, will not raise all that much because of the poor forward flow, the poor cardiac function curve. And similarly, the hypervolemic will have an even greater distending pressure. So this patient may have a significant ventricular interdependence effect seen if you were to do a bedside echo and look at how the RV begins to impinge upon the LV. And again, all of these patients, same drop in intrathoracic pressure, but changes in volume status and changes in cardiac function curve will render each of these patients with very different hemodynamic responses to the same drop in intrathoracic pressure. So that was talking about the Mueller maneuver, just only a decrease in intrathoracic pressure. If we tack an increase in lung volume on top of that and analyze the effects, well, that's a spontaneous breath. And so looking at spontaneous ventilation in the right ventricle, this implies both a drop in intrathoracic pressure and an increase in lung volume. So looking at this on the Campbell analysis, you're dropping intrathoracic pressure and you're moving further into the page on the z-axis, so that is lung volume is going up. And again, this patient, as I've drawn it here, to have normal lung compliance, normal airways resistance, and normal chest wall compliance. And this is gone over in quite detail in Chapter 1. So again, here is the distending pressure. This is your measured right atrial pressure, or CVP. This is the normal cardiac function curve, a normal venous return curve. So let's go over this again. So this is your intrathoracic pressure at FRC. The patient breathes in. The cardiac function curve shifts leftward with that breath. The distending pressure increases, okay, as the patient reaches their lower intrathoracic pressure for the increased volume. But what happens is, as the lung volume increases above functional residual capacity, the right ventricular afterload tends to increase. And I talk about this both in Chapter 2 and Chapter 3, in that there's two populations of blood vessels in the pulmonary vascular tree, alveolar and alveolar and extra-alveolar. And at functional residual capacity, your pulmonary vascular resistance is at a minimum, and as you go above functional residual capacity, the alveolar vessels are compressed and your pulmonary vascular resistance goes up. So that would tend to drop your cardiac function curve minimally in health, very minimally in health, when you increase your lung volume above functional residual capacity. So that's what I've depicted here. What I've talked about here is that, you know, and I talk a little bit more about this in Chapter 3, that, you know, because your afterload on a ventricle is actually the wall stress that the ventricle feels. That's that recapitulates Laplace's law, and that's equal to the transmural pressure of the ventricular wall multiplied by the radius. So as the radius increases, as you dilate your right atrium or your right ventricle with a negative inspiratory breath, and you increase preload, just the simple distension or increasing that radius, increasing the radius of curvature, that in and of itself increases the afterload, the wall strain. And then as you increase the pulmonary vascular resistance as lung volume goes above functional residual capacity, that also tends to increase right ventricular afterload a little bit. But the addition of the increase in lung volume has effects on the venous return curve. And when the volume of the thorax increases, it also tends to pressurize the abdomen. When you contract your diaphragm with an inspiratory effort, spontaneous inspiratory effort, the diaphragm drops, the volume of the abdomen decreases, and therefore the pressure goes up as a function of the abdominal compliance, and the volume of the abdominal organs. So as you pressurize the abdomen, you tend to decrease the capacitance of the abdominal vessels. And a silly analogy for this would be sort of be like lying on a waterbed. And if you sort of think of the waterbed as like the boggy venous capacitance vessels where 70% of your blood volume lies, and you were to, you know, open up the nozzle for the waterbed, well, you know, water would gush out. The venous return would occur just as a function of the stressed volume of the waterbed. And then if you were to lay on the waterbed, that would be a little bit like increasing thoracic volume and increasing the pressure of the abdomen. If you were to lay down on it and increase or decrease the capacitance, you would then increase the pressure head for flow, and you could imagine water coming out of the waterbed at a faster rate. And I think maybe less intuitively you could appreciate that if you were to lie on a very full waterbed, a hypervolemic patient, for example, then you would augment venous return much greater than if you were to lie on a waterbed that was half full or only a quarter full. And in fact, if you were to lie on a waterbed that was only a quarter full, you may actually impair the water coming out of it. And that's kind of what's been shown. A number of investigators dating back to I think the mid to early 80s have shown that stimulation of the diaphragm can augment IVC flow. And it was really put together by Takata and colleagues in the mid-90s, I believe, and they showed that essentially, and they used the data from Brower and colleagues in the mid-80s who looked at this in terms of the lung. That is, if you increase lung volume, you decrease the capacitance of the pulmonary vascular bed, and depending on your fraction of West Zone 3, the more West Zone 3 you have, i.e. how full the water bed is, the more West Zone 3 is, when you increase lung volume, there's a greater outflow of blood from the lungs. And similarly in the abdomen, if the patient is very hypervolemic and there's lots of quote-unquote West Zone 3 physiology in the abdominal splanchnic beds, then decreasing the capacitance would augment IVC flow and venous return to a much greater extent. So, long way of saying that as you increase thoracic volume with the inspiratory breath, you functionally increase the mean systemic filling pressure by decreasing the capacitance that's laying on the waterbed. And if the patient is very hypervolemic, there's lots of West Zone 3 in the abdomen, you will augment venous return through the IVC, and you may actually augment cardiac output. Whereas if the patient is hypovolemic and there's lots of West Zone 2 or West Zone 1 physiology in the abdominal splanchnic beds, then you actually may increase the resistance to venous return, actually decrease IVC flow. So this is going to be a variable effect on your venous return. It'll be a variable effect on the distending pressure of the right atrium and right ventricle, and it will be as a function of the patient's underlying volume status. And that's what I just said there. So now we're going to move along to Chapter 4 and give you some highlights of Chapter 4, and that's applying the same analysis that I just did in health to various disease states. And I go through a number of them in Chapter 4, but I want to highlight ARDS here. So ARDS on the right ventricle, there's been conflicting results regarding the effect of positive pressure on right ventricular size and function in ARDS. And I think that this can be accounted for by this nice distinction that was given by Luciano Gattinoni and colleagues in the late 90s. And this is an often overlooked article in the Blue Journal. And they propose this really kind of neat distinction between pulmonary ARDS and extra-pulmonary ARDS. In both states, there's a big reduction in the compliance of the respiratory system, leading to high peak and plateau pressures that you measure with the ventilator, the proximal trachea. But in pulmonary ARDS, the abnormality is impaired pulmonary compliance. And these patients were primarily direct toxic insults to the lungs, classically an aspiration pneumonia or a bad pneumonia that's blossomed into ARDS physiology, and it's typified by consolidations that can't really be recruited, and this results in very high transpulmonary pressures as less of the airway pressure is transmitted to the pleural space. And I have a cartoon and a couple of slides that I think might better illustrate this. In these patients, lung volume will not change greatly. The elevated transpulmonary pressure is thought to increase the right ventricular afterload. So if you sort of think of the pressure inside the alveolus less the pressure in the pleural space, that's the distending pressure of the lungs. And that's also the pressure that the alveolar capillaries feel. So as at the point at which the transpulmonary pressure supersedes the transmural pressure of the pulmonary arterioles, so if you think of the distending pressure of the pulmonary arteriole versus the distending pressure of the lung tissue around it, once the transpulmonary pressure supersedes the transmural pressure of the pulmonary arteriole, then the blood vessel will collapse, and that will increase vascular resistance, and it will therefore increase right ventricular afterload. And then by contrast, they describe this extra-pulmonary ARDS, which similarly resulted in poor respiratory system compliance. And when I say respiratory system, I'm referring to the lungs and the thorax together. But the primary problem for the primary driver of the decrease in respiratory system compliance was the drop in thoracic compliance. And they didn't really get into the pathophysiology of this, but it was thought to be due to, it tracked nicely with increased intra-abdominal pressure. So a lot of these ARDS patients were, the ARDS was the result of, trauma, pancreatitis, abdominal sepsis, these insults that are occurring outside of the lung but affecting the lungs by proxy. And These patients tended to have more atelectasis and edema that could be recruited with positive pressure, but nevertheless, there's still very poor chest wall compliance. The reduction in chest wall compliance when you apply pleural pressure while it increases plateau pressures, there's a great increase in the pleural pressure, not in the transpulmonary pressure. And it's the pleural pressure that you can sort of think of that affects cardiac loading, cardiac preload. As the juxtacardiac, this juxtacardiac just means the pressure around the heart. As the pleural pressure goes up, it affects the juxtacardiac pleural pressure, which affects the pericardial pressure, and that tends to change biventricular loading conditions. So if you can imagine an increase in pleural pressure, there'd be more of a preload reducing effect. So this is my little cartoon. So this is my hokey ventilator, and we're going to administer a fixed volume to all three of these situations. So this is the balloon in the box analogy. So this is a normal lung compliance, and this box is the chest wall compliance. This is the normal respiratory system compliance. So this is, you could say this is extra-pulmonary ARDS. This is a poor chest wall compliance. This is, or you could say tense ascites or severe obesity, anything that's going to drop the thoracic compliance but preserve pulmonary compliance here. This is the low chest wall compliance. And then this is the pulmonary ARDS. This is the direct toxicity to the lungs, where pulmonary compliance is really reduced, but chest wall compliance is normal. So what are we going to do? Well, I'm going to administer the same volume to each of these patients. So what's going to happen in the normal patient? Well, the lung is going to increase, the balloon, and it's going to push out. Again, these patients are all heavily sedated and potentially paralyzed, so that they're not making any inspiratory efforts, so they are not confounding changes in intrathoracic pressure and volume. So watch that again. So you're going to give this patient a breath. The lung is going to expand and push out against the chest wall, and it's the pressing of the lung out against the chest wall that determines the pleural pressure or the intrathoracic pressure. That's the pressure between the inside of the lung or the alveolus and the chest wall. That's the pleural pressure. That's the pressure that the ventricles feel in terms of their preload. Okay? The transpulmonary pressure is the difference in pressure between the inside of the alveolus or the lung and the pleural pressure. Okay? So what's going to happen to this patient here? Well, the lung is going to increase in volume because of as a function of its normal compliance, but as it starts to press out against this very stiff, non-distensible chest wall, you can imagine that the intrathoracic pressure, the pleural pressure, is going to increase to a much greater extent than the patient with the normal lung and chest wall compliance. Well, let's look at the patient with pulmonary ARDS, with very poor pulmonary compliance. You're going to give them the same volume, but there's going to be much less of a volume, there'll be much less of a volume change, and there'll be much less of a intrathoracic pressure change. But you can imagine that the pressure inside the alveolus compared to the intrathoracic pressure is going to be much greater because of this poorly non-distensible lung. So in this patient, there'll be a very high plateau pressure, a very high driving pressure, but a high intrathoracic pressure or pleural pressure. In this patient, there'll also be a very high driving pressure or plateau pressure, but that's going to be mostly this high transpulmonary pressure. And as I mentioned, it's that transpulmonary pressure that causes collapse of the alveolar vessels, and that actually tends to afterload the RV. So this extrapulmonary ARDS, I think you could imagine, would tend to reduce the preload of the RV, whereas this would tend to increase the afterload of the RV, and this is the distinction here. So if we want to think of it in terms of the Campbell and Guyton analyses, this is pulmonary ARDS. Remember, going back to chapter 1, this is kind of my modified Campbell diagram. This is pulmonary compliance. This is resting chest wall compliance. This is where they meet at functional residual capacity. The x-axis is pleural or airway pressure. It's airway pressure when you consider the compliance of the respiratory system together. So this is the pressure that is applied at the proximal trachea to affect a given volume, and the slope of this curve reflects, I should say, the relative compliances of the lung and chest wall together, and I'll illustrate that here. So if you imagine a significant decrease in pulmonary compliance, so this would be pulmonary ARDS, that's the non-distensible lung, FRC drops, and now it's for each volume here, it's the lateral distance. It's this, again, this is pressure on the x-axis. It's this lateral distance. This is the pressure that must be generated by the muscles of respiration to generate a given volume on the y-axis. In a patient who is, heavily sedated and potentially paralyzed, this pressure then becomes the amount of pressure that the ventilator must apply at the proximal trachea, or the airway pressure, to determine to achieve each of these volumes. So then if you were to plot each of these pressures that you must apply at the airway to achieve each of these given volumes along the z-axis, well, then you can see that the respiratory system compliance drops. And so essentially these are just serial plateau pressures from the ventilator. The curve shifts down and to the right, so then for a given plateau pressure, for a given volume, the plateau pressure is greater. Okay, as I mentioned, this is the plateau pressure. But as I talked about in the previous slide, or sort of implied it, I guess, the pleural pressure in the heavily sedated and potentially paralyzed patient, the pleural pressure follows the chest wall compliance curve, or the chest wall elastance curve, and you can sort of picture it as the lung pressing out against this paralyzed chest wall. If the chest wall compliance is fairly normal, then as the lung volume increases and it pushes out against this chest wall, it's the determination of the two coming together that makes your intrathoracic or pleural pressure, and that's the pleural pressure here, and this is the airway or plateau pressure here. So really it's this lateral distance between the pleural pressure and the plateau pressure. This is your transpulmonary pressure. So this is kind of like your right ventricular afterload here, and this is your right ventricular preload determination here, your intrathoracic or pleural pressure. So really in the heavily sedated and potentially paralyzed patient, what determines intrathoracic pressure is, in the numerator, it's tidal volume, and that's gonna be what essentially you dial into the ventilator in a volume-limited mode of ventilation, over the chest wall compliance in the denominator. So in this patient, when the drop in the thoracic compliance, or the thoracic compliance is synonymous with respiratory system compliance, is due to a drop in the lung compliance, less of the airway pressure, so this is the airway pressure, is transmitted to the intrathoracic space. And in pulmonary ARDS, there's also been noted increases in airway resistance. So that would be, if you go back to chapter 1, this is the additional pressure that must be applied at the proximal trachea by the ventilator to overcome the resistive effects of the lung. So that's an additional amount of pressure that's applied, but it doesn't really, that's in addition to the amount of pressure that must be applied at the trachea just to maintain volume. That's so-called static pressure. This is a so-called dynamic pressure. And in contrast to extrapulmonary ARDS, this is a significant drop in chest wall compliance. So follow the chest wall elastance curve. The resting chest wall compliance. Elastance and compliance are inversely related, so sometimes I use them interchangeably. So there's a drop in your chest wall compliance. Again, FRC drops. And similarly, the drop in chest wall compliance increases the lateral distance between the two lung and chest wall curve for any given volume. And again, in the spontaneously breathing patient, this is the amount of pressure that must be generated by the muscles of respiration, or in the ventilated patient, this is the amount of pressure that must be applied to the proximal trachea to achieve this given volume. So again, if you're to plot these out, you'll see that the respiratory system compliance, just like pulmonary ARDS, is also reduced. The airway pressure to volume curve is shifted down and to the right. But it's not because of the decrease in pulmonary compliance, it's decrease in chest wall compliance. This is the extrapulmonary ARDS. And you can see that while the plateau pressure is going to be high, your intrathoracic or pleural pressure is going to be much higher. So this is that balloon pushing out against the stiff box, and the lateral distance for this given volume between your plateau pressure and your pleural pressure here, this is your transpulmonary pressure, and you can see it's much less. Transpulmonary pressure, or the right ventricular afterload, is much less for extrapulmonary ARDS compared to pulmonary ARDS. And this may explain why, as we'll see, the higher intrathoracic pressure has more of a preload effect on the RV and less of an afterload effect. So let's graph this out. So this is pulmonary ARDS. Again, this is your Campbell diagram down into the page on the z-axis. I have, just for clarity's sake, I've omitted the pulmonary compliance curve, which would be bent down and to the left because of the poor pulmonary compliance that you get with pulmonary ARDS. This is just the chest wall compliance curve, and then this is the airway pressure curve. So that's why it's pleural pressure or airway pressure. On the x-axis, again, this is 0, this is above atmosphere, this is below atmosphere. So this is the, essentially this is your plateau pressure volume relationship here, or the compliance of the respiratory system together, and this is just the chest wall. So let's go through a thought experiment before we see what the effects on the cardiovascular system are. If you were to apply PEEP from this patient at functional residual capacity here at this intrathoracic pleural pressure, again, this patient is sedated and potentially paralyzed. As you apply PEEP, lung volume increases, pushes out against the normal chest wall compliance curve, and increases intrathoracic pressure along the chest wall compliance curve like that. If you're, so just to read what I've written here, the large reduction in the respiratory system compliance is due to the poor lung compliance, which I've omitted from this graph. Therefore, the pleural pressure increases, but not to the same extent as the airway pressure. So at the end of PEEP, this is your transpulmonary pressure. If you were to measure an airway pressure and end expiratory pressure and measure your pleural pressure, you now have a greatly increased transpulmonary pressure. If you were then to apply a breath on top of that, again, this is your airway pressure that you would measure on the ventilator, the transpulmonary pressure would go up to even a much greater degree during that inspiratory breath. But this would be your transpulmonary pressure at the end of the application of PEEP, and then I don't even have it illustrated here, but this is your transpulmonary pressure. It would sort of be this lateral distance at the end of the breath. So we can go through that same thought experiment now with the superposition of the Guyton analysis. So this patient, their right ventricular cardiac function curve is shifted somewhat down and to the right because of this increase in right ventricular afterload. This patient might be a little bit volume overloaded. Say their venous return curve is shifted to the right because they've received a lot of fluids. They're in the intensive care unit. Maybe they're anosarchic. So their distending pressure, their measured CVP or right atrial pressure, less their intrathoracic pressure at FRC, is pretty great. So you might start to see some RV distension already. So if we apply PEEP to this patient, as you apply PEEP, again, it has a couple of different effects. The first effect is that it shifts the right ventricular cardiac function curve rightwards as a function of the increase in intrathoracic pressure from here to here. It also further shifts the right ventricular cardiac function curve down and to the right. You can see that effect here, like that. But also, as we talked about, as you increase intrathoracic volume, you tend to pressurize the abdomen and shift the venous return curve somewhat rightwards. So that tends to even facilitate venous return to a greater extent and distend the right ventricle even more. If you then apply a breath on top of this, you're going to have an even more pronounced effect. So this is the positive pressure breath above PEEP. You're going to increase the transpulmonary pressure to a much greater extent, and you may actually severely afterload the RV during that transient breath that you give, and may actually cause right ventricular failure. And so this is why you may, in patients like this, you may see more of an afterload effect, more of an RV distension. And in patients with poor cardiac function at baseline, this could be quite detrimental. And then conversely, moving on to the extrapulmonary ARDS, which we talked about, was a severe decrease in chest wall compliance, as you can see here. And again, I've omitted in this patient presumably a normal pulmonary elastance curve, the very profound drop in their chest wall elastance curve, if you apply PEEP to this patient, their intrathoracic pressure will follow. Again, this patient's heavily sedated and potentially paralyzed, so there's no inspiratory efforts. Intrathoracic pressure will increase to a much greater extent as it was in the patient with the normal chest wall compliance. And again, this represents the plateau or airway pressure here for given volume. This is the compliance curve of the respiratory system, and on the x-axis we have the pleural pressure or the airway pressure, depending on which curve you're looking at. If you then apply a breath on top of PEEP, well, then you're going to have an increase in the resistance, or there's an increase in airways resistance that occurs with ARDS. So the peak pressure may be actually way out here, and then the plateau pressure at the end of the breath will be higher too because of the decrease in the respiratory system compliance, which in this case is being driven by the drop in chest wall compliance. But here at the end of this inspiratory breath, the transpulmonary pressure is much decreased compared to the previous breath. So just running through the cardiac function curve again, or the Guyton analysis, now when you apply PEEP to this patient, there's going to be a much greater rightward shift because of the increase in intrathoracic pressure. The increase in thoracic volume will pressurize the abdomen, shift the venous return curve rightwards, which would tend to facilitate a little bit more venous return, but you can see that the distending effect is much less in this patient. In fact, there may even be a diminished preload because of the increase in intrathoracic pressure that you get with extrapulmonary ARDS. The low transpulmonary pressure tends to preserve the RV afterload, so there isn't that great big increase in RV afterload that you see with pulmonary ARDS, and so RV ejection is maintained. But the high pleural pressure or the high intrathoracic pressure reduces the right ventricular transmural pressure and has more of a preload effect, so the RV tends to shrink inside. So a breath on top, again, there's minimal or no change in the right ventricular afterload or right ventricular function. It just continues to shrink the preload of the RV, so you have less of a transmural pressure and more of a preload effect in extrapulmonary ARDS. So that was my overviews for really the meat of all of these talks for Chapter 3 and Chapter 4. Thanks for sticking in. I don't think that made sense. Thanks for tuning in. Thanks for sticking with it. And hopefully you tune into the full versions of Chapter 3 and 4, and you can get a sense of all of the wonderful physiologic abnormalities that are going on in your critically ill patient, and it will help you interpret your bedside echoes better. It'll help you interpret your intraluminal pressure measurements better, IVC collapse and IVC distension better, and it'll stimulate discussion on rounds in the intensive care unit. Thanks again.